Good afternoon, everyone. Thank you so much for being here for our webinar on approaches for teen dating violence in healthcare. My name is Kaylee Cornelielsen, and I am the lead program specialist at the Adolescent Health Initiative. And I'm partnering with some of my great colleagues at the Injury Prevention Center here at the University of Michigan to present this content for you all. I'll let them introduce themselves in a minute, but first I want to give you just a really quick overview of the Adolescent Health Initiative, or AHI. AHI provides technical assistance, training, and coaching to healthcare providers, health systems, and organizations across the country to improve adolescent-centered care. And our vision is really to transform the healthcare landscape to optimize adolescent and young adult health and well-being. We do that through a lot of different methods. And one of those ways is through webinars, which we're really excited to share this content with you all today. And just going to pass it off to our experts on the topic, Quinn and Vijay, and let them tell you a little bit more about themselves and dive right into what they're going to speak on today.
Yeah, thank you, Kaylee. I'm just going to make sure I can take over these slides. All right, and I'm going to go back to the first one just so you can see who we are. I might introduce myself first and let my colleague Quinn introduce herself then. So I'm Vijay Singh. I'm a family medicine physician. I see patients here at University of Michigan Hospital. My kind of teaching and research interest is in intimate partner violence, including adolescent dating violence, teen dating violence. I'm one of the faculty members, part of this injury prevention center we have here at University of Michigan. I'll give maybe the first half to not quite 2/3 of the slides, and then my colleague will join in, but maybe I'll let her introduce herself here.
Great, thanks Vijay. My name is Quinn No. I am a clinical psychologist by training and also research faculty here at the Injury Prevention Center. My research area really focuses on the intersection of substance abuse and intimate partner violence, in particular perpetration and aggression. And I do intervention development, particularly from a trauma-informed perspective. So that's what I will be bringing to the discussion today. And I'm going to turn it back to Vijay to give some background and information on teen dating violence to kick off the webinar.
Yeah, thank you, Quinn. So I'll just try to advance through those slides to the point. So as a general outline, we've got kind of 4 general sections before we'll leave probably a good 10 minutes at the end for dedicated time for questions. I believe you can type questions into the chat function, and our moderator Kaylee will try and address those either as we're going through slides or definitely at the end. So I'll kind of talk about teen dating violence from in many ways from a healthcare perspective. Quinn and I tried to bring in perspectives outside the healthcare system as well in the slides. So I hope that helps we know this is as a broad audience that interested in adolescent health initiative topics. I'll give background on the topic and prevalence. I'll launch into then the process in healthcare to identify and respond to adolescents, to identify if they've experienced dating violence, how to respond to that. We'll move on to a section on mental health and trauma-informed care that my colleague Quinn will discuss, and then we'll together talk about the future for the field, teen dating violence in healthcare maybe specifically, but thinking about it broadly as well, what we're hoping to learn through time. So to go through background, so first I'll talk about prevalence, like how frequent is this? Well, before I get to prevalence, actually I should say, adolescent health and adolescent-centered care does include a young person's physical, social, emotional life, and that life includes their relationships with romantic partners, with peers. We'll talk about prevalence in just the next slide, but there is what I think most people would consider to be high prevalence of the problem, multiple related health issues that are potentially consequences of the behavior. Despite that, this is a topic that's often overlooked in the healthcare setting. And it's at least partly related to just a lack of provider training for somewhat for adolescent topics, kind of broadly speaking, but maybe more specifically about the issue of teen dating violence. There are many providers who've had limited to no training on this topic as pediatricians, as family medicine physicians, or as probably even school-based nurses, other healthcare providers. We don't get a lot of this, so this webinar can serve to increase that training. And this, before I get to prevalence, just talk about kind of background, like in some ways, kind of like the etiology of the problem. What causes dating violence, or in this case, what do we know is associated with dating violence, or which you could consider as partner violence when amongst young adults or adolescents. An adolescent who as a child experienced emotional, physical, or sexual abuse. Those are part of a conglomeration of events in a young person's life. We call them adverse childhood experiences. They do create greater risk of teen dating violence. Teen dating violence is a risk for partner violence as an adult and all of its health consequences that can last a lifetime. Adverse childhood experiences also include in the household if a young person witnessed amongst their parents partner violence, or if their parents had substance use problems, mental illness problems, incarceration. You'll see some of those, substance use, mental illness, prior history of partner violence. These are, things highly associated with teen dating violence. Adverse childhood experiences may be a precursor to impaired learning or behavior. They may lead to kind of disruptive behavior that could include teen dating violence. ACEs have been shown to be linked to physical and mental illness in adulthood. So now for issues on prevalence. So there's an annual survey called the Youth Risk Behavior Surveillance Survey. It shows that amongst women, female high school students, in the past year, about 1 in 10 students experienced physical or sexual violence. And to put it into perspective, there's another large national survey called the National Intimate Partner and Sexual Violence Survey. It says for adults, so 18 and over, I think they were including up to 64-year-olds, for both men and women, the prevalence of violence from a partner is about 5%. So that's for adults. So this is 10% for adolescents. So it's about double amongst younger people. There may be various reasons for that, which maybe we can discuss later, but suffice it to say 1 in 10 students of high school age, so 9th, 10th, 11th, 12th, experience violence from a partner. This violence can include severe enough injuries that include death. So there was a study published earlier this year looking at something called the National Violent Death Reporting System that showed about 135 adolescent girls between 2003 and 2016 killed because of a dating violence partner. That was maybe then 10 a year through that time period. For adults, similar data is around 1,000 women a year killed. So there is obviously a differential in that, but there still is, the process of identifying and responding to violence amongst adolescents can be life-saving, as there are young women who are killed each year due to violence, dating violence. So health conditions. So I bring these up now not only to show consequences of dating violence, things that could potentially lead to dating violence, but also these are things that I look for when I'm working with patients, that if they have some of these problems, these are people, adolescents, who I would want to ask about this problem. So mental illness, kind of mood disorders, depression, anxiety, post-traumatic stress disorder symptoms, suicidal ideation plans, and attempts are all highly associated with dating violence, as are alcohol and substance use. Adverse reproductive health outcomes, of course, for young women, it can be men as well. Sexually transmitted infections, unintended pregnancy if there is contraception that's being controlled by a partner. Some people call it reproductive coercion in the literature. Some of these may be due to partner violence. And then certainly injuries. You may not see necessarily injuries in a non-healthcare setting, but certainly in emergency settings. Adolescents, adults present to healthcare for treatment of injuries. And in those cases, we should ask about what the cause of the injuries was. Looking then at the process of identification and response for our my kind of next section. So thinking about adolescents that may have certain health problems, like I described, mental illness, alcohol, substance use, adverse reproductive health, injuries. These are adolescents who I might want to talk to about dating violence. And a critical part, and in some ways I think could be the most challenging part of the process once you've actually learned what are the questions, how to identify and how to respond, it's how do I get this patient alone? If there is another family member, certainly a parent, a friend, you don't know if that friend, say in the room up here, is a perpetrator of violence towards this adolescent or may know the perpetrator. Having a person alone can decrease their safety risks when asking these questions, so that a perpetrator does not know that their partner is being asked these questions. So I mean, there's various creative steps you can take. I do work in a hospital setting, so in an overnight stay for a young adult, there's generally some time when the adolescent is alone. It might even be in the middle of the night. I just coordinate with my staff, social workers, psychologists if they're on site, nursing team to try and ask question of the adolescent if there's not good daytime hours available. In an outpatient setting, in a school-based setting, it could be more challenging, but in general, I think most people accompanying someone to the healthcare system know that there's often a few minutes alone that the patient has with the patient. That could include during the physical exam time. And if there is a lot of pushback to getting the patient alone, you could ask the other person in the room, are there certain questions that they're concerned about that will be asked? And that could create a discussion around the topic. But also, if you can't get someone alone, you might just have to think about the next time I'm with that adolescent. That may be the better time to ask these questions. For introducing the topic, this is the idea in the literature. They talk about like a normalizing statement, like so that an adolescent doesn't feel singled out for being asked the questions or feeling like they've done something wrong that's prompting the questions. You could say a statement like conflicts with partners, problem for my patients because it affects health and well-being. I ask all my patients about it. Could be having a discussion about safe and healthy relationships because it has a large impact on health. I might often say if I find someone who's got some mental health issue, substance use, injury, I might say, I've worked with many patients who have that problem and they're also experiencing relationship problems. Can we talk more about that? And again, giving the patient, taking permission from the patient to ask more of these questions can make a patient feel more empowered. Next, I'll talk about legal reporting. This foreshadows this idea of confidentiality statements or shared decision-making. But in the US, so 47 out of our 50 states mandate reporting of instances where a patient has an injury. We are, speaking from the state of Michigan, just as an example of one of these reporting laws. In Michigan, physicians have to report to law enforcement if a patient has a recent injury in need of treatment and caused by violence. So this is only in the healthcare setting, in a school-based setting, in other environments, that's not required. And it's a fairly narrow definition of they have an injury, they go to the healthcare site to get treatment for that injury, and they tell you that this injury was caused by violence. I've probably screened at least 1,000 patients, maybe more, for partner violence, and there's probably only 10 times where I've had to actually make a report. So that situation of disclosing violence that caused an injury from a partner is a fairly rare situation, but for healthcare specifically, that is something to think about as we want to be truthful to patients about confidentiality of what's been spoken. What might be more broad is the idea of child abuse. So physicians, mental health workers, school personnel report as child abuse if the perpetrator of the dating violence is in a position of authority or power. And so this is not like peer-to-peer relationship. This is like, you know, the perpetrator is a, you know, teacher or a caregiver. You know, the adolescent maybe views it as a dating romantic relationship when in fact it's just abuse of the child. Those are situations where you'd have to make a report. Those are situations where we want to let adolescents know about confidentiality. So informing patients to the limits of confidentiality is important for acute violence-related injury or, you know, potential for child abuse. I often phrase this by saying something like, after my normalizing statement, before we get started, I want you to know that everything you share with me is confidential. Unless you have an injury due to violence, or if I think that there's child abuse that's happening, I'd have to report that situation. Is it okay that we continue? So I still ask as an open question, is it okay if we continue talking about this topic? And if someone says no, then I won't ask those questions then, but I may think about their hesitancy to talk about it could suggest there could be violence. There's maybe after the slides, we can talk about ways to universal education approaches to allow patients to know about violence happening in society in ways they can get help without them having to specifically identify that it's happening to them. But after our confidentiality statement, there are multiple surveys, questions that exist to ask about partner violence or dating violence. I'm going to talk about a screen called the Abuse Assessment Screen. The citation you'll have at the bottom of the screen in just a couple slides. It's about 5 questions long. This has been used amongst adolescents in the US and international settings. Have you ever been emotionally or physically abused by your partner or someone important to you? This ever question is kind of the lifetime of that young person, so it's not just the past year. Someone important to you could include someone besides a partner, so it does bring up if there is, you know, a parent, or it's like a bullying situation. Is there something else? So this is a somewhat broad screening tool. I'll give a different example in my next slide. But the other questions for this abuse assessment screen in the past year. So like recently, have you been hit, slapped, kicked, otherwise physically hurt? So these are physical violence questions. Since you've been pregnant, I'll talk about pregnancy risk in just a couple slides, but pregnancy, a woman being pregnant, a young adult certainly being pregnant, does create higher risk of violence, and specifying that to pregnancy, have been slapped, kicked, otherwise physically hurt by someone. If we want to ask these questions of, say, young men, we could exclude this question on pregnancy. In the past year, has anyone forced you to have sexual activity? So this is a question on sexual violence. And then finally, are you afraid of your partner or anyone you listed above? So specific for partner, a fear of partner can be a question about safety, which we'll talk about in the next slide. But it can also get a sense for emotional kind of control or psychological aggression that's happening in the relationship. This next question, it's called the HITS screen, H-I-T-S. You'll see the H-I-T-S bolded here. I think it's a simple mnemonic to remember a question about physical violence, you know, like hitting. So I tend to use this one just because it's easier to remember. But the questions are, does your partner physically hurt you? This is a question on physical violence, of course. Insult you or talk down to you, threaten you with harm, scream or curse at you. Those are questions on emotional or psychological aggression. There is a screen for it called the extended hits, the E-hits, which adds an additional question. Has your partner forced you to do something sexual you didn't want to do? So in that sense, you cover physical violence, emotional aggression, and sexual violence. The HIT screen has got the highest, you know, sensitivity specificity in the literature. It has less been used in adolescents, but I still use it in those settings. Then this idea of safety assessment. So I mentioned earlier about pregnancy as a risk. So we've published a study that shows that the leading cause of death for pregnant women in the US is homicide. So is being killed by a partner, so partner violence basically. So, and I say this to bring that up as a point about how pregnancy is a time when we have to think of safety for women if there's violence. And even if someone's not pregnant, we can think about questions on safety as well. There is a 5-question screen done in the academic medicine, in the emergency medicine literature. It's been shown in the nursing literature as well, to assess if someone's at high risk for injury or even death due to violence. First question, has physical violence increased over the past 6 months? Is he violently and constantly jealous of you? So this is, phrased in a very gendered way. We could think about both genders as we need, depending on the adolescent you're working with. Do you believe he's capable of killing you? So a very stark question to get at homicide risk. Have you ever been beaten by him while you were pregnant? So, I mentioned about pregnancies, high risk time for women. This has that question specifically. And then has he ever used a weapon or threatened you with a weapon? 3 of those 5 questions denotes high risk. Even one of those, I would say, would need more what we call safety planning for the patient. And I'll talk about that in my next few slides. My colleagues who developed this instrument have also focused on the question on choking, like if someone tried to has your partner tried to strangle you or choke you? That's an additional question. But all are risky situations for a patient to be in. Other validated measures, these have, again, specifically been used with adolescents. There's something called the CADRI, Conflict and Adolescent Dating Relationships Inventory. It's 4 questions. It's basically based on this next instrument called the CTS, or Conflict Tactic Scale. The scales are the different tactics where conflict can happen, basically emotional abuse, physical abuse, sexual abuse. It also has a section on injury to a partner. There is a short form, 10 questions on either victimization or perpetration. It's often used as the gold standard, kind of more in research settings, I think, than clinical settings, but it is available. And the reference I have at the bottom is a Centers for Disease Control based kind of table of a compendium, basically like a booklet of different screening tools that can be used in healthcare settings. And I think it's a nice reference, and it gives the pros and cons and sensitivity, specificity for each instrument. I think it's a good one to look through. So then if you've asked your question, is someone physically hurt you, and if your adolescent says yes, there's a process that you can do. It doesn't have to just be in a healthcare setting. Like, this could be even if family members want to use this process when interacting with their child. There's something called first line support. This is based on a model from the World Health Organization that I think is useful. This process of first line support identifies patient needs and concerns. It uses a process where you can listen to and validate patient concerns and experiences. And the process has been shown to help people feel more calm, hopeful, connected to others. This reference from 2014 is this kind of manual on how to use it, again, designed for healthcare settings, but I think applicable, this first 3 steps applicable in non-healthcare settings. So they have a mnemonic from WHO called LIVES. And now the first 3 are about first line support. The L is listen, the I is inquire, the V is validate. I'll talk briefly about the kind of second steps, the E and the S, as we get to those slides. But listen, this might sound obvious as a definition, but we'll go into it in a little bit more detail in a moment. Listening to the patient closely with empathy without judgment. Inquiry, assessing and responding to patients' various needs and concerns, their emotional concerns, physical concerns, social concerns, they're very practical concerns. Validation is kind of statements you make to the patient that show that you understand and believe them, means that you believe what they say without judgment or conditions. So listening, to kind of drill down on it a bit more, The purpose is to give a patient a chance to share their experiences in a safe and private place. That may be in a healthcare setting, it may be in a school-based setting. There could be various places where you have your adolescent alone. But giving them a chance to share their experiences, and I say this just, it's this idea of allowing some silence for a patient to reply, because these are maybe things that they've never talked about to anyone else. And it may be, they may be kind of processing the trauma of thinking of the situation. It may take them time to actually speak about it. Using your nonverbal cues or being aware of your body, you know, can suggest, you know, sitting next to them in a chair, you know, looking at them at eye level, hands down at your side, leaning in maybe a little bit can help you listen better, but also just shows that you're interested. Nodding your head certainly as they're speaking can let a patient or adolescent know that you're listening and you want to hear more about what they're saying. Just trying to advance the slide here. Sorry, sometimes it's a little slow, but I talked at least about there we go. Allowing for silence, as I mentioned, giving patient time to think. Like, this may not be something they've spoken about. This idea of staying focused on the patient's experience, it kind of borrows from ideas of motivational interviewing, where it's a process to, you know, talk to patients about challenge, or adolescents, anyone, about challenging topics that it's hard for them to discuss. If you may feel like talking about another adolescent, you know, that was in a violent relationship who got out and is fine, or some of your own life experience or friends, that may be helpful for the adolescent, but at this initial disclosures, it kind of detracts from their speaking about this difficult topic, and staying focused on their experience will allow you to learn more about what's going on with them and allow them to less easily change the topic to someone else. Acknowledging how a patient is feeling is kind of using your listening skills and even just kind of visual observation of looking, does the patient look agitated? Do they look sad? You know, frustrated, reticent to speak, depressed? There are moods or feelings that you may sense from a patient that if you label them, if you speak them to the patient, if you reflect back to them what they're feeling, they often feel that this person really understands me, and they may be willing to talk more about it. The I in lives for inquiry, you know, learning what's most important for the patient. And, you know, what's most important to them may not be something that you've thought about. You know, it may be something about their parents. It may be something about that peer or some other friends for that person. It may be things that you just didn't even consider. And inquiring, what can I help you with, as an open-ended question can allow you to get to that. Reflecting back feelings is kind of what I described earlier about acknowledging them, kind of, you know, vocalizing, saying what it is. And that could be in a summary. Like, you could say something like, you told me that yesterday, you know, your partner, you were at home at your parents' home, but no one else was there but your partner, and he hit you, and then he abruptly left, or whatever it might have been. Can you tell me, am I understanding that correctly? Like, that summary would have shown that you've listened to what they've said, and I'm just kind of hypothesizing a story of some act of violence, but telling a patient what you've heard them say, summarizing back to them, and maybe even adding, if there's some emotion, that you felt really upset about this, you were really confused, you know, you needed to find other help. Getting at those emotions in the story you can clarify through an inquiry, but can be really validating for a patient, of knowing that this provider or this other trusted adult is saying that it actually happened. Validating statements, you know, let patients know that feelings are normal, that it's safe to express them, like, I'm sorry this happened to you. No one should be hurt by their partner. I'm concerned this may be affecting your health. That can foreshadow other questions about health, or even, I'm concerned this may be affecting your safety. Can we talk more about safety? That E and S in lives relate to enhancing safety, providing support. But before I get to that, just that end part for communication tips. Avoiding questions that suggest blame, you know, the why did you, is it why, just is often people feel it as an accusatory kind of question. So you might say, how, can you tell me more about, how is it that, or, you know, what more would you like me to know? what were you doing there alone is just getting this idea that an adolescent may already feel like they shouldn't have been alone with that partner then, and this just makes them feel potentially more blamed about why they were alone. They didn't have other help available. So just being thoughtful about the questions I ask and how I say it. The patient may omit or avoid painful, frightening, horrific details. My colleague Quinn will talk about trauma-informed care in a moment, but it's this idea of not forcing a patient to describe what otherwise sound like really painful or frightening, horrific details. If a patient wants to tell you that, that's fine, and that just gives you more to document about putting in quotes in your medical record or in some other source if you've got where you put your information, what a person's actually said. But this idea of not forcing them to give more info, because it can be frightening. It can be painful for someone to think through. Things to avoid, trying to persuade a patient to leave a violent relationship. I think that, unless, if you've had some experience with training in the topic, you probably know. So a patient is at highest risk of being killed by their partner during the first, say, at least 3 months after they've left their partner. And some data shows it out to a year. We might think that having someone leave their violent partner might be a great way for the violence to end because they've actually separated from the partner, so maybe there'll be less violence in the relationship. But that can actually be a high-risk time. So if a patient, adolescent, wants to ask you about how am I to go about leaving, you can talk about it, but you just, might want to think in terms of the safety plan in that situation and just try not to persuade them to do it. It's their right to stay in a relationship if they need to, even if it's violent, and it may be safer for them to stay in the relationship rather than leave because they might have a sense that this person's already threatened me if I leave, that they're going to shoot me or do something else horrific to me. So we just have to think a lot about their safety as they're leaving. Not convincing a patient to seek other services. So, I think most people think of the criminal justice system, the legal system, police, probably first when they hear about some violent act. I think that most adolescents or certainly adults, they probably would have gone to that service already if they wanted to. If they're speaking to you about it, they probably just want some extra forms of support. And some, patients, some victims feel re-victimized if they have to go to the police or legal system, and if it's not addressed in a trauma-informed way. And we'll talk about those trauma-informed ways in a minute. And then, like I mentioned before, not asking detailed questions that force someone to relive painful events. It's often just hard for someone to focus on the content of the questions you're asking if they're like feeling frightened like they were as they think about that event that was violent towards them. So that was kind of a discussion about safety planning. In some way, we went through a safety assessment. So resources, so like what support is available? Providing a referral to a health system or school-based counseling source for advocacy support, safety planning. If you're in a health system that has it, that's great. If you're in a school system, that's great. You've got maybe some of those systems available, some people with expertise in it. And if you don't, there is the National Domestic Violence Hotline, 800-799-SAFE. That's 7233. That's a number someone can call 24/7 and get some support, questions about safety. There is a National Dating Abuse Helpline, so it's like the National Domestic Violence Hotline, but it focuses on adolescents. It does have a website, as does the National Domestic Violence Hotline. People often use texting to that service. They are available. It could even be if you want to give an adolescent support, you could even just call that number in your clinic, in your office, and if a patient's willing to accept that call, just hand over the phone. That way there's no trace of a phone call being made to that domestic violence hotline or dating abuse helpline. That can be a way to provide resources. There are various interventions that have been used outside the healthcare setting that have evidence to show that violence reduces. The Centers for Disease Control is a program called Safe Dates. It's a school-based curriculum program. There's been multiple studies that have come out of it since its original publication in '98, but it is kind of a curriculum about healthy and unhealthy relationships. There's something called Coaching Boys into Men. So in the community setting, in sports settings, coaches could use a manual to talk about healthy relationships with their, say, male young men in their sports teams. That's been shown to reduce dating violence. What I described about the healthcare response is kind of based off this randomized controlled trial, this advocacy intervention published a couple years ago. It goes through these steps of advocacy, safety assessment. And the Centers for Disease Control and Violence Prevention website has more information, more studies, more interventions that you can look at. So I'll let my colleague Quinn talk about mental health and trauma-informed care.
All right, thank you, Vijay. So I just want to start a little bit with this idea that with regard to mental health, symptoms may present differently in adolescents than in adults. So if you're used to working with adults, or if you have listened to a lot of conversations around depression or anxiety or trauma symptoms in adults, know that they may present a little differently in adolescents. So in adolescents, developmentally, the executive functioning portion of the brain or higher level thinking systems, as many of us know, are not completely developed yet. They are developing, and many adolescents are learning not only about themselves, but relationships and what's normal, what's not normal, what's healthy, what's not healthy. And much of that comes from the media, but also the adults in their lives. And so the way that adolescents may be in relation with a dating violence, a situation where there may be dating violence, may be really different than an adult who knows him or herself better. So with adolescents, depression can actually come off or present itself as being very argumentative, very combative. It can present with a lot of behaviors where you would perhaps label them more as not so much depression, but more delinquent behaviors. Sorry, I was losing my words there for a moment. But they may present as more delinquent, and we may be more likely to label them as such, when in actuality, maybe depressive symptoms or anxiety symptoms or trauma symptoms. And so keeping that in mind, that for adolescents who may be in a relationship where they're experiencing dating violence, they may come off as more angry, and in those moments may pull from us this sense that they don't want our help, or they perhaps aren't deserving of our help because of how difficult that they're being, but remembering that where they are developmentally, this is normative, and it's really the process of figuring out how you deal with these difficult situations. On the other hand, you also may have adolescents who are sort of the stars, star pupil, star student, star child, where they follow all the rules, yes ma'am, no sir, and they're really conforming to our ideal of what of how a child or adolescent may behave, and that this can also be a red flag. And I guess I say this so that we keep in mind that these mental health symptoms can look really different in adolescents. It's very context specific. It really depends on each situation. A lot of different adolescent specific factors that may be present, but may be indicative of a relationship where they're experiencing some kind of violence or aggression. So moving from there, I'd like to talk a little bit about traumatic exposure and trauma-informed care. We hear a lot about trauma-informed care. It is becoming sort of this hot topic right now. But what exactly does this really mean? And how do we provide trauma-informed care? How do we discuss this with adolescents? And how do we know what to do here? So according to the Substance Abuse and Mental Health Services Administration, they have the 3 E's of traumatic exposure. The first aspect of that is the events and circumstances that cause trauma. So it is the actual thing or triggering event. It's also informed by an individual's experiences of that event. So some individuals may have been traumatized by a particular event that occurs, whereas other individuals would not be traumatized by that same event. So it also is very specific to the experiences of the individual in that. The effects of trauma can include physical, social, and emotional or spiritual consequences. So it can really impact an individual at every level. And what can be difficult is that this can be almost impossible to disentangle. So there may be physical symptoms that are actually more indicative of an emotional or psychological response to trauma. So it's important to keep in mind that the entire person and their experiences of an event inform how traumatizing that event is for an individual. So for trauma-informed practices, there are 4 R's to keep in mind. One is realizing the widespread impact of trauma on the entire system. So not only the body, the psychology, the emotion, the mind, the spirit, but also the people who are connected to that individual. So when one individual is traumatized, often it has an impact on the friends and family who are around them as well. Recognizing trauma signs and symptoms, recognizing those trauma signs and symptoms by the healthcare providers within the patients and others involved in that situation is also really important. Healthcare providers can also recognize not only the trauma symptoms that they see in their patients and the families and friends of those patients, but also the secondary trauma that you may experience as a healthcare provider. And so being very aware of your own triggers and your own responses to seeing trauma, it can be very difficult to watch someone else who is deeply in pain or who has experienced a very horrific event. And so being aware of your own trauma responses, the triggers that you may have, because ultimately your responses and the impact of these traumas that you're exposed to do affect the ways in which you interact with patients. The third R is responding by fully integrating trauma knowledge into policies, procedures, and practices. So ensuring that not only are the practitioners and healthcare providers within an institution or a structure are aware of what trauma symptoms are and how we work to alleviate trauma symptoms, but also what are the policies and procedures that we have in place that can further increase traumas. So a lot of sexual assault survivors have talked about the experience of being interviewed throughout the process of reporting and how traumatizing that is. And so thinking about the policies and structures in place that can alleviate some of that, how we ask questions, how we share information, and who shares this information. So for instance, an adolescent who's experiencing a dating violence incident may not want to hear from a doctor. They might feel more receptive to hearing this information from a nurse or from a social worker, or perhaps because of cultural factors, they may take that information in more fully from a doctor versus a nurse or a social worker. So that all really depends. But thinking about how these structural and institutional practices affect trauma-informed practice as well. And the fourth R is really thinking about resisting the re-traumatization. So forcing individuals to recount in detail how their dating partner hurt them or the things that the dating partner has said to them. You know, for legal reasons, there may be a need to document specifics of the experiences of teens who have experienced dating violence, but really keeping in mind that this can be re-traumatizing for adolescents. And so if it's necessary, what are the things that we have in place to support adolescents as they work through the process of discussing what's happening to them and processing that experience. And sorry, trying to advance here. Is it delayed? Oh, okay. So after thinking about the trauma-informed care and what goes into being trauma-informed, oops. Sorry, now it's moving too far ahead. There we go. It's important to think about the stages of trauma and the ways you address the different stages of trauma. So the first and foremost, I'm going to talk about this as if they happen in a linear way, but individuals, adolescents can and probably will bounce back and forth between these different stages of trauma healing. So the first and very important part of healing from trauma is safety and stabilization. So ensuring that the adolescent feels safe, but also that any symptoms of trauma are stabilized. So what are their triggers? Are they able to, you know, stay in the moment and not be triggered so that they are not able to respond to your questions adequately, or you know, that they aren't reliving things. So making sure that their symptoms are stabilized, that they feel safe, is really the first part of working through trauma with adolescents. Things to consider here, particularly for adolescents, is that if they're reporting dating violence, oftentimes they also have to deal with the social fallout from reporting something that happens. As we know, abusers can be very good at manipulation, at framing things in a way that really re-victimizes the victim all over again, but in a broader social scale. So so there can be a lot of reasons why teens do not want to report it, don't want to discuss it, and really are just wanting to deal with it on their own. So ensuring the safety and ensuring symptom stabilization is really important in the process of trauma. In the same token, if you are working with a teen who is experiencing something very difficult like dating violence, it's important for you also to have a sense of safety, but also to know that if you're being triggered, you're stable as well, because you will do your best work and be best able to help adolescents if your stress symptoms and stress responses are also stable. And the second process in the healing from trauma is processing and integrating these traumatic experiences. So being able to say, yes, this happened to me, this is a part of my experience. Moving from there and probably going back and forth between there and making meaning out of that traumatic experience. So yes, this happened to me. It does not define who I am completely, that this is something that I have experienced and is part of my history, but it's not me. And so moving through these different stages, oftentimes adolescents may, be working through processing or integrating these memories, making meaning out of these memories, and then all of a sudden become triggered and unstable. And at that moment, it's really important to take a step back, to go back to stabilizing and establishing safety. And so while sometimes we think about this in a linear pattern, it really is not such a linear pattern. So there are 6 principles according to SAMHSA for trauma-informed practices. And the first is safety. So ensuring that there is a physical safety for adolescents who are experiencing dating violence, but also, again, the interpersonal interactions are safe. So ensuring that if you are providing services or interacting with an adolescent who is experiencing teen dating violence, that they feel a sense of safety in their discussions, but also that when they walk out of your office or when they go back into their homes or their communities, that they feel as safe as they can or have spaces where they can go to feel safe. The second principle of trauma-informed approach is trustworthiness and transparency. So really establishing that the adolescent is in charge of how quickly things go as much as is possible, and the course of the healing or the steps taken, that there is some sense of being able to make decisions, that the adolescent can make decisions in those instances. And transparency by providers. So if you are a mandated reporter, making it very clear to adolescents that you are a mandated reporter. You know, one fairly common practice among mandated reporters is to say, you know, this is one of those instances where as a minor, I am required to report. So, you know, let's think about how to do this. Let's think about how maybe we can do this together so that you're not just surprising an adolescent with a report, or someone doesn't just show up at their doorstep with a report that you've made without any kind of warning. Again, that can be another re-traumatizing experience. Another principle of trauma-informed approach is really around peer support for survivors. So for those who have experienced teen dating violence, speaking with other teens who have gone through the same thing, or even adults who have gone through the same thing, maybe when they were younger, so that there is a sense that this isn't necessarily an isolated incident, that it happens to other people, and that there's hope for recovery and for moving on and for healing from that experience. The fourth principle is collaboration and mutuality. So this is the idea that, again, the adolescent who is going through teen dating violence has some sense of power, that it isn't just a provider or an adult who is telling that adolescent what needs to happen or how things are going to happen, but that there is a sense of consulting with that adolescent on what's happening in his or her life. And the fifth principle is around power, voice, and choice. So really helping support adolescents in developing positive coping skills, in developing the ability to advocate for themselves and to find ways of maintaining health, and both in terms of individual health, but also relational health in this process of healing from trauma. And then finally, there needs to be a sensitivity to cultural, historical, and gender issues. So for much of the research and history in teen dating violence has focused on girls as victims and boys as perpetrators or aggressors in teen dating violence. But in fact, the data that we see coming out now shows that boys may be victimized as often as girls are in terms of teen dating violence. Now, there are differences in who is more likely to be injured. So girls are more likely to be injured. So there are some gender differences there in terms of dating violence. So this is not to say that there's parity by gender, but that boys are also victimized, girls can also be the aggressor, and to be very careful about our assumptions around victims and aggressors when we're talking about teen dating violence. There are also some cultural factors to take into account as well. If you have a teen who is an immigrant or part of an immigrant community, and the aggressor is also a member of that community, then there can be very major impacts and consequences to reporting teen dating violence, and so there may be more reluctance there. There can also be historical factors as well in terms of teen dating violence. For instance, more marginalized communities in the United States may be less more reluctant to come forward and talk about teen dating violence if there are histories of structural oppression or issues with different professionals or providers historically with those communities. And so keeping all of these things in mind as you think about trauma-informed approaches, both from working with teens, but also in being very sensitive to your own experiences and responses when you are working with teens who have this level of traumatic experiences. So now Vijay and I are going to talk a little bit about the future of the field and what we hope to learn.
And I'll just interrupt to say, I know it's about 26 or 25. So Kaylee, I can't tell if there are chat questions, we could address those if we want, if people have to jump off the call soon, or we could go through this slide if there are no questions.
No questions currently. So if folks do have questions, now would be a great time to chat them in while Quinn and Vijay go over the future of the field and what we hope to learn.
Yeah, thank you, Kaylee. Just our first point about further developing healthcare-based interventions. So there are not many randomized controlled trials that really show which interventions might be best. A lot of this data is based on what people call an advocacy intervention. So looking at how health outcomes change for adolescents who've experienced violence, or using techniques like trauma-informed care, mindfulness, motivational interviewing. There are really not many of them. There's no meta-analysis of these randomized controlled trials yet to really guide us on what would be best to do. So seeing more work on that would be great. I mentioned briefly during the talk about what's called universal education approaches. So it's the idea of, rather than having to screen someone or have them disclose that yes, violence happened to them, this is an approach that Liz Miller's used with University of Pittsburgh, division chief for adolescent medicine. Kind of, you might have used brochures or little pamphlets, trifold pieces that talk about safe and healthy relationships, violence in relationships, where you can go to get help. Universal education approaches is the idea of just kind of going through the card with an adolescent and then asking, does any of that, resonate with them? Is there any experience like that they've had? It's a little different than the kind of screening questions, and it's an approach that I think can be useful. It's only been used in one RCT that I know of. Tailoring interventions for risk, I think is partly the idea of all these other combined risk factors, that are difficult for many adolescents to talk about: substance use, mental illness, pregnancy. Certain adolescents may have higher risk based on, a certain number of risk factors that they have. Tailoring those interventions for that individual risk, I think, can be helpful.
Yeah, and as Vijay mentioned earlier, when he talked about adverse childhood experiences at the beginning, there may be different adverse experiences that would require different types of tailoring in terms of intervention. And I would also put a plug in there for the idea that many of the interventions that we've looked at have focused on addressing victimization or survivorship. And I would advocate also for working with aggressors and perpetrators of teen dating violence, given that this is a two-sided issue. And we know from the research that many perpetrators and aggressors also have a history of trauma and victimization. And so we really need to approach teen dating violence from both directions, both working with victims and survivors, but also with perpetrators and aggressors as well, in order to really fully address the issue of teen dating violence.
We did have one question come in, if we could take that now, just because we're getting near the end for time. Mm-hmm. So this question actually relates to something that I was thinking about while you all were speaking. So historically, dating violence or intimate partner violence, especially for adults, has focused so much on kind of the gender binary, focusing on men as perpetrators, women as survivors. And Quinn, I think you were speaking a little bit to how the research on that has really started to shift, and we're seeing more that especially adolescent boys can also be victims. And I'm wondering also about any information on non-binary folks who we might know how they might be experiencing dating violence. And the question from the audience was also about gender disparities and mental health outcomes among the victims.
Absolutely. So in terms of the interventions and the work that has been done, unfortunately, most of it is very heteronormative and really considering gender from a binary perspective. When in fact, we do know that sexual minorities and gender minorities are at greater risk of violence in general, but also potentially intimate partner violence for multiple social and political and community cultural reasons. And so that is a place where there is a great need for more work. I think it includes training of healthcare professionals, but mental health professionals as well, to understand the unique needs and risks associated with being marginalized because of gender or sexuality. And then Kaylee, what was the other piece of your question?
Yeah, so the other part of the question that came from the audience was they were asking about gender disparities and mental health outcomes among victims.
Absolutely. So in particular, for male victims, and again, you know, this is a gender binary discussion here because that's where the research has been. But in terms of disparities in mental health outcomes, boys who are victims of teen dating violence have very few resources. So there are very few interventions that even acknowledge that boys can be victims. But then in terms of places for boys to turn who have been victimized, there are few to no resources for them. It is much harder to admit if you're a boy and you've been victimized. You know, there are questions then of your masculinity and how could you let that happen to you? And so there are all sorts of complications in terms of boys and their mental health following experiences of teen dating violence. Now, whether or not there's actual research to look at what exactly are, you know, how much of a disparity there is, I'm not sure that there's much of that. If anyone has really looked at that, it's really sort of been separated out in this very gender binary way. So unfortunately, I don't have that information, but we do know that there are very few resources for boys to turn to, and there's very little discussion. In fact, most mental health and medical professionals don't even screen boys for teen dating violence. And that is a conversation that is really needed.
Yeah, I'll just say that, you know, in the absence of, you know, data or studies to help guide it, we could use principles like I've described for both men and women. I did show, you know, some data more on this kind of gender binary way, because I think that is a traditional way to look at it, but that's where the data is. Like, you know, I can separate out for men and women, for girls and boys, what the data is. And, you know, there's some of the citations actually does that. But I think particularly the idea of gender identity as opposed to sexual orientation and different than just gender is truly an under-researched topic. And with time, more of that will come. But, you know, first line support, you know, trauma-informed principles, they're similar for regardless of someone's gender identity, their sexual orientation, their gender, and they can be used for both.
And we have one more question come up while you guys were speaking. Thank you for replying to that. The question is, how can providers balance empowering teen survivors with the need to involve parents in teens' decision-making, acknowledging that parents and teens have differing opinions about how to proceed?
Absolutely. I think, you know, and Vijay may have other thoughts about this, but I think that this is an instance where, as a provider, it's really important to have transparency there. So, you know, teens generally aren't stupid people. And so having honest conversations with them about the fact that, you know, you are a minor and legally we've got to bring your parents in. So how can we do this together? Because I want to support you. I want to be here with you, but we do have to bring your parents into this in some way. How do you want to handle it if they disagree? How can I help guide this conversation so that you still feel supported, or you still have a space or an ability to disagree and to assert what would be important for you. So that, I think, is really where it's working with adolescents and treating them not like children, but as individuals who are beginning to learn how to advocate for themselves and how to function as adults, because that is the major developmental task of adolescence and emerging adulthood. And so I think it's really important to involve them in that moment. Now, ultimately, you also have to be very frank with adolescents about the fact that their parents may do things that they disagree with. And so figuring out, helping adolescents with how to navigate that, how to work with that. And then as a care provider, talking to parents as well about, you know, listening to adolescents and understanding that, you know, right now they're a minor, but we also need to teach adolescents how to take care of themselves, how to advocate for themselves. And part of that begins with respecting what they're saying now, even if we don't always agree with it, even if we make different decisions than our adolescents would like us to make, it is important to involve them in that conversation and have them be heard.
Yeah, I agree. I know we're kind of short on time. I mean, I think clinically, it's just, you know, talking with an adolescent, if they feel that they will get resistance from their parents for discussion of the topic, understanding more about why, helping them think through what their own thoughts are, talking with them separate from their parents to get the adolescent's perspective, because they may feel inhibited if the parents in the room. Doing that's important, and trying to shepherd the family towards some beneficial outcome is challenging, and there's not necessarily a right answer in some situations, but you know, working with them as best you can. Being an honest broker in the room and being a helpful adult can be something. If you model that for the adolescent, they may feel that maybe if not their parents, then maybe some other adult could be useful to talk to.
Yeah. Yep. Agree with that.
Great. Thank you so much. I think those are all the questions that we have for now. Did you have any final thoughts and that you wanted to share with the participants?
I was just going to see if there's anything else.
I mean, yeah, I mean, so I mean, we just had a couple of other thoughts around, you know, directions where the field could go, but you know, that's it. I think we're good if you all are good too.
Yeah, I'm sure this will be cataloged. The slides will be available. We put our emails on the first or whatever was slide, so people can contact us if they want with questions. We're happy to provide input.
Absolutely.
Great. Thank you so much. And yes, I will send out these slides in the follow-up email, as well as with a link to the webinar recording. I want to thank you all so much for being with us today. You can connect with the Adolescent Health Initiative via our website, Facebook, Twitter, Instagram, and also would love for you to save the date for our 7th annual conference on adolescent health, which will be April 20th through 21st in Detroit. And more than half of the sessions at our annual conference are co-facilitated by youth presenters. So we would love to see you there to continue the conversation on how we can better serve our adolescent population. Thanks so much and have a great day.
Thanks, Kaylee.
Thank you.